Okay, so welcome everyone to our Innovations in Healthcare panel discussion and networking. I'm Professor Judy Davies. I'm the Deputy Director for Quality, Diversity and Inclusion and also the MBA Health Director. So if you haven't applied yet and you do want to apply for September, you have until Thursday to do so, any of your friends. And we're launching the EMBA Health, which is purely distance learning, the following September as well. So I'm very grateful for you showing up in person because we don't do this very often, and I think this is the only time so far this year we have done it as a public event. So I really appreciate seeing you in real life, someone said to me the other day, IRL, as well as our people online live streaming on YouTube. So I'm very grateful to Nora, Professor Nora Colton, if you don't know her, is the director of the Global Business School for Health, who suggested this event. Also to Adam Vidler, who's in charge of organising everything, Christina, who did a great job with us in shifting furniture, amongst other things, this evening. And also to our great panel of very interesting speakers. So we have Hassan, Anna, Lara, Lloyd, and Leonid, who are going to speak each for 10 minutes and then open it up for Q&A. If you do want to tweet, feel free. Isaac, you're the right age to be doing this kind of stuff. Feel free to, any bright ideas, do put it up on @UCL_GBSH. And I'm just going to go through a couple of slides just to kind of contextualize our discussions. And really asking three questions. So who are we? You know, what is UCL and what is GBSH? What is innovation? And the third one is what are the kind of enablers and trends that can help healthcare innovation in leadership and management? But we did promise you that this would be about networking, so I thought we should do a little bit before we go through the slides. So what I'd like you to do is to turn to someone in a minute who you don't know, and we'll give you 3 minutes just to say hello, who you are, why you're here on a beautiful June evening. And I'd like you, I thought I'd do a bit of a news quiz actually. So what do these two images and what does this date have to do at all with innovation? And can you see any commonalities between the three? That's a really hard question. Okay, so I'm going to give you 3 minutes just to chat. And those of you online, feel free to write in the chat box. So turn to the person behind you, next to you, someone you don't know. Say who you are, and then say how you think these might relate to innovation. think of where we are at the moment. Don't think too hard about your history. I mean, more generally. Okay, thank you. Very heated discussions there. Right. Okay, so I guess it depends how you define innovation, doesn't it? So we'll go on to that slide in a minute. So any thoughts on Emma Raducanu? How did she innovate in any way? What's new? What's news? Laura?
I'm out of the tennis league.
Nora, you had a tennis scholarship once upon a time, no?
Yeah. Well, she won the U.S. Open, and it was a long, dry period for the Brits. So no, she, she made history, I suppose.
Yeah, that's my kind of take. She made history. She wasn't supposed to win. She didn't do particularly well yesterday, but she got through, thanks to, the supporters, I think, and the fact that she's a home girl, although she was born in Canada and her parents are from elsewhere. So I kind of think she's made first, certainly. She's the first in Britain. She's our top British woman tennis player at the moment. And she did well yesterday. And she, as you say, won the Open, and we've had a hell of a dry run. And she's doing particularly well. Okay, 1826, historical buffs here. Go ahead.
Fine year of UCL.
Excellent. Yeah, so UCL was founded in 1826. It was the first university in England to allow people who weren't members of the Church of England to come to university in England, and admitted women on the same basis as men for certain subjects. So if you were Jewish, Catholic, whatever, you couldn't come to university. At King's College London, you couldn't. And yesterday in The Guardian, they featured Afro-Chenchics, if anyone is a Guardian reader. Any thoughts on that? Put you out of your misery. Okay, so UCL yesterday, there was a big thing in The Guardian saying how great UCL is. It produces 10 billion a year for the economy in the UK. And one of these entrepreneurs who, one of the alumni of UCL has got this company that's doing very well in Afro hair. Okay, so I hope that kind of got you meeting a few people at least you didn't know earlier on. So a little bit about us. We're almost 200 years old as a university. So we're pretty ancient, though not quite as ancient as some of the Scottish. And a few weeks ago, in the belated Research Excellence Framework for 2021, we came top for medicine, health, life sciences, economics, social sciences. So I think you're in good company if you want to be in an elite institution, but also a very welcoming institution. So we're the only really elite university in London that's fully rounded. You can go to London School of Economics, you can go to Imperial, but here you find very, very strong STEM, and you find, like here, humanities, which I think is a great advantage. So this logo is from the new, looking at innovation, the new campus, UCL East in QE Olympic Park. So I think it's quite interesting. You've got a 200-year-old university, and then you've got a global business school for health, which is it a year old yet?
Well, no, not from the launch in September.
Yeah, not even a year old. So it's a startup. So we are aiming within GBSH clearly to innovate ourselves, to do interdisciplinary, impactful research. And we are the first business school in UCL and the first business school in the world dedicated to health. So I think it's very important learning from our panel this evening, how we build into our curriculum, how we innovate ourselves when we're at UCL East and not just at Bloomsbury as well. So we have a mission statement here of what we're trying to do. We're at the intersection of health and business. So a lot of medics, hi Dave, a lot of medics, talking of one, surgeons and dentists I've spoken to, they loved their curriculum, very, very nice, but it was purely clinical. They had very little management exposure unless they happily went, like David, to Imperial for a year. So we're looking at things how do you change the systems, how do you lead and manage in healthcare so that you have ethical systems and you can improve healthcare outcomes. And obviously slowly, very closely linked to the UN Sustainable Development Goal 3 of improving health and well-being for people at all ages. So our offerings for September are postgraduate master's programs taught. We have a range of those. We will also be offering a PhD in health, doctorate in business administration in health for people who want to stay at work, mid-career, late career, and do a thesis and a viva. Lots of executive education. There'll be briefings in July and August online about those and in person. And consultancy projects and research. So if you have opportunities for students as employers, I know some of you are employers, we have students on the MBA who will go to Saudi, India, and Nigeria for their group project, but they'll all be doing individual projects that they'll want to advance their careers, like management consulting, I know Leonid is in. And why this was launched, clearly the pandemic's very timely. There's a huge divide between what the demand for healthcare and the supply, and a massive shift because of the pandemic onto telehealth. And clearly we have various crises of funding, war, cost of living, food security, and so on. And very recently in the UK, the Messenger Pollard review that talked about bullying, burnout, lack of leadership in the NHS system here. So there's huge strains and continuing chronic problems, obviously, with aging, lifestyle diseases, funding inequalities, and just general burnout. So it seems timely for us to be talking about innovations. If we can't necessarily find more people, how do we innovate our way out of these crises? So in Vienna every year, despite the fact that he died quite a while ago, there is a conference annually for business people, academics, and top people talk about Peter Drucker, who was a management consultant, kind of practitioner, bridging the kind of worlds that we're trying to bridge at GBH of practice and theory. And I think it's quite useful what is innovation and how complicated are these models. You know, is it just about something new, a nice bright idea? On the other hand, how do you sell it? How do you embed it? So Peter Drucker's definition was about exploiting change and creating opportunities. He listed these 7 kind of innovation opportunities. Maybe something goes wrong, something goes right in your organization. You realize perhaps that's the way you should be doing your business model. Or there are anomalies in the system. There are market changes, structural changes, demographic changes. So those of you who are entrepreneurs might put yourself in those boxes, or you might find someone else far more inspiring than Peter Drucker. Just to touch a little bit on, as an academic, we have to kind of embed it in the literature a little bit occasionally. So my colleague Ewan Furley at King's College with colleagues has written about why don't we innovate? So in the Academy of Management Journal, they concluded that often it's because of social and cognitive differences between professionals. You know, dentists don't talk to speech therapists. You know, you look at the body as a specialist, but you don't look at it holistically and talk to your people in other bits of the profession or social care, government, industry, banking. So these divides between the professions and being, you know, very, very good at what you do, very unidisciplinary, but the world and the wicked problems that we face are multidisciplinary. So how do we bridge those? And more recently, Jerry George at Georgetown in the Journal of Management Studies, who was at Imperial in Singapore, did a study of HIV in India and concluded, you know, it's all about communication and coordination between people and also between public and private. I mean, all of these are no-brainers, really. So where we position ourselves is how do we produce these T-shaped professionals, these hybrid people who've got depth, maybe as clinicians or lawyers, as well as generalists who can cross boundaries, like Patrick Vallance, who used to be the head of the medical school here and now is in government and was at Glaxo and is a medic himself. So how do you get those kind of people who can 1 minute talk to Boris Johnson, the next minute talk to civil servants, and then you talk to, investors and so on. So these kind of people who can translate, these hybrid professionals who are maybe excellent clinicians but also excellent leaders as well as entrepreneurial, I think is very important. And they can change systems and move across these boundaries. And just in The Economist this week, there was an article about the big tech firms moving into health innovation. 3.6 trillion per annum dollar industry in the US, 70% of GDP at least. And Alphabet particularly they were looking at and talking about how it's working with L'Oreal, to try and keep us living longer and looking more beautiful longer. Microsoft, cloud-related services, Apple, smart watches, and Amazon pharmacy and so on. So clearly this is big business. And then I just had a quick look at this futurist, Bernard Marr, who's based in the UK. And I think he quite nicely summarises some of the trends and innovations in healthcare. So you've got this, how do you prevent disease? How do you predict illnesses? How you democratise? How do you get access to healthcare? Personalisation, digitalisation, biohacking, so you can get kind of target individual cells, robotics, nanobots, with your nanobots, datafication, Internet of Medical Things, medical records, all those kind of things. And then finally, I had a quick look at MIT and Harvard, what they were doing on their boot camp for innovators, actually. It was quite interesting what they were up to. And these were the kinds of questions they were asking the innovators at their boot camp. Are you really solving a real-world problem that your customer understands, or do you just have a really bright idea and it's like really nobody wants it? So how do you ensure your idea is sustainable, your innovation, financially, and in terms of key decision makers, and you develop trust in your startup and build it up and scale it up? So hopefully our 5 panel members will touch on some of those kind of contextual issues. And we've picked them particularly because we wanted diversity, so it's great. We've got people from different sectors. Hassan, you have multiple roles, I can see, and you're moving into another one. So I can see you've got experience in Department for International Trade and with Cancer Hub and commercialisation. Then we've got Dr. Anna Grossman, who's at the University of Loughborough in London, and the QU Park with us, who's an expert in innovation and entrepreneurship, worked as a strategy director herself, and in M&A and investment banking and corporate finance. Lara Mott has trekked up from the beautiful beaches of Bournemouth, goodness knows, to London, and has a great app that looks at real-time feedback data, that's my understanding, in the NHS, and was a first as the British Medical Journal's entrepreneur in residence. So that's great to hear. And then Lloyd Price, I interviewed the other week, is on GBSH YouTube, who's a serial entrepreneur from what I can see. And then Dr. Leonid Shapiro, who has joined us from Candesec, who used to work for McKinsey, and so on. So I'd like to hand over to you guys to continue the discussions. So what we're going to do, we're going to have a train journey through these different 5 stories. I've asked each of the panel members to tell their stories, give us some stories, and give us some takeaways. And then we'll have a Q&A at the end, if that's okay, and various refreshments to keep us ticking. Okay, so Hassan, over to you. Thank you very much.
Yes, please. Thank you. Thank you so much, everyone. I hope to take us through a question. Why is innovation in digital health so tough? So 2 parts to the agenda. The first, actually, I say 2 parts. There's actually a third if I get time, right? So the first is about or on innovation. Why is it so hard to get it right? And then within the why is it so hard to get it right, there's 7 steps. But the other point I wanted to go into, if there's time, is what do I mean by innovation in digital health? So let's talk about innovation and technology, and they are not the same. The most important thing that I'd like to do before I get to a definition is separate these two things out. So historically, a consistent mistake in the UK in healthcare has been to focus on technology, not on people, not on their needs. The best example, perhaps, is the National Programme for IT, which was an attempt to install single electronic patient records to get a single record across the country. We gave up at various stages, kept spending money, kept burning money. At one point, it would have been cheaper to burn money. £10 billion was the estimate, described as the biggest IT failure ever seen. It was embarrassing, and it set the UK's leadership in this space back. So I was lucky for the UK government to go out to South Africa way after this had happened. This was 2019. And when I presented, someone came up to do the response to me, and it was, well, the UK has definitely moved on from National Programme for IT. That was their first comment. So what do we mean by innovation? I think it's difficult to pin down, even in general terms. So I'm going to cheat by just going to the literature, which is what we should always do, right? There are three phrases that always appear in the literature. I say always, 99% of the time. Novelty. There has to be either something that is completely new or at least new to the context. The second, there's a deliberate application component. You're trying to do something. So innovation by accident, that's a contested area. You've got to be seeking an intended benefit. Some of you are thinking penicillin at this moment, right? So an intended benefit. Western FAR 1990 is probably the most accepted definition for innovation. The intentional introduction and application, and it says within a role group organization, of ideas, processes, products or procedures new to the relevant unit of adoption, designed to significantly benefit the individual, the group, or wider society. So this definition and others contain those three elements: novelty, application, intended benefit. There are some people that discuss innovation as the end product rather than the process. This is an innovation, but that's completely outside the scope of what I'm talking about, which is the process. How do we develop innovation? Now, why is it so hard? I think that there's 7 different steps. Do innovators really understand the problem they're solving? And I think that was given early on, just before me. And I believe that it's not enough to understand the problem at the level of your customer. You have to love that problem, fall in love with that problem, more than your customer, or at least independent of your customer. Because if you don't show that you love that problem independently of them, they'll see that you're inauthentic, that there is a problem where you're just trying to sell something. If you independently care about that problem, that matters. So I was lucky, Lara has a podcast, and that was the title that they sent it on afterwards. Have you fallen in love with the problem? Now, if you have, great. Do you own it, or do you pay lip service to the idea? So I'll just leave that image to linger in your mind for a second. Second point, do you think, if you're an innovator, that you're the hero of the story? That you're going to ride in and save the day and everyone's going to love you? No. You should realize, in healthcare, you will only ever be helpers. You will only ever be guides. You're Gandalf. So I'll just leave that picture just to sink in for a second. Third, do you realize no one cares about your product? Your product doesn't mean anything. I wake up, I'm brushing my teeth. I care about my product. But if you're trying to sell me your product, I care about waking up. I want my tea. I want my coffee. Buyers care about what the product does for them. So there is a long conversation that we can have about how you need to be thinking about the customer and what they need rather than what you're trying to sell. And we can go into that in the Q&A. But you've got to get your story and narrative right. You've got to sell the sizzle not the sausage. Or the very original, don't sell the steak, sell the sizzle. That is the original. I'll let that picture linger. Do you realize the buyer might not be the user? Might not also be the beneficiary. In healthcare, you have this fragmentation where whoever's buying is buying on behalf of a population, and the population, this might really be, I'm buying on behalf of my clinicians, and the clinicians will use it, but guess who benefits? It's the patient or the carer. So there's a fragmentation along here. You're not directly speaking to the right people. Do you realize that you've got multiple stakeholders that you've got to get to buy in? Do you realize you need different messaging? It's almost like you're doing international relations. So I will leave that picture of the UN Security Council for you for a second, because you do need different messages. Do you realize, as innovators, that the health system is full of perverse incentives that stifle the adoption of innovation? A really obvious one is that you have a patient who's stuck in a bed, ready to go home, but social services don't have services for that patient for the discharge, for the safe discharge. So guess what happens? Social services benefit from not stepping in. They save 2, maybe 3 days worth of money. What happens to the hospital bed? It's blocked. So what happens to someone in A&E who wants to get into the hospital? They're blocked. That's a perverse incentive, right? Where one part of the system benefits but another one loses. I remember working on a drug. It was GSK and Amgen, and it was Prolia. And I can talk about this now. I'm not under NDA. So it was an injection. And the reason why this injection, this was for women postmenopausal. So they had hip fractures. They were at risk of hip fractures. And we knew that the injection was better than giving them the IV, sitting in a hospital chair with an IV bag. The problem was the injection had to be administered in the community to save money, because the drug itself was more expensive. But no one trusted the GPs to do it. And the GPs themselves didn't want to take on the risk, because they weren't being paid. So because nobody wanted to do this, the drug, which was better for women and would save hip fractures, which would be not just a quality of life issue, but at a certain age, you have a hip fracture, the chances of you having a second, a third, and then dying magnified exponentially. Do you know that you've got to align the economic case for the system in healthcare? You do. You're not in the system, but you have to make that case, and you've got to demonstrate it repeatedly. So I thought, how can I get a picture of a perverse incentive? And I thought, Dilbert. It's always Dilbert. So I'll leave that picture for you for a second. Do you realize you can't just simply drop technology into healthcare use cases without trying to look at how you might model transformation? You've got to think about, and this is my longest part of my presentation, clinical effectiveness. Of course, you've got to prove your product is clinically effective if that's the area. You've also got to prove financial impact. They're essential. But what if you don't model for human factors, which is all the non-clinical, non-financial? For example, there's a system that makes it easy for a patient, or supposedly easy for a patient, to book appointments for their primary care, for the GP. But the receptionists hate it. So even though it has, on paper, 24 million patients under contract, it's not been switched on everywhere because the receptionists hate it. And that's a human factor. So, Ronald Heifetz. Now, I'll admit I'm a Heifetz nerd, right? This guy, he got it right. And the book, Leadership Without Easy Answers. So this is his big innovation. He talked about problems as technical. So type 1, the first column. Type 2, they're technical and adaptive. And the difference here is, for the first one, the problem's easy to define, and there's someone who can define the problem alone. In type 2, there's a bit of sharing of how you do this. But type 3 is where the problem is so challenging to define, both sides need to learn to solve the problem. You can't just plug and play. No fire and forget. type 3 adaptive. The responsibility for the solution is actually greater on the person with the problem than the expert. Does that describe healthcare? It does, right? It describes the people who are delivering care, and you're in IT, or you've got an app. It's also the patient who's thinking, I want to look after myself, right? So healthcare's full of adaptive problems. The most common leadership failure stems from trying to apply technical solutions to adaptive challenges. One of the reasons why we continually fail in healthcare, in transformation, is because we don't understand the problem requires learning on both sides. I am already out of time, right? Ooh. Okay, there's lots and lots of quotes, and you can take my slides. If I give you these pictures, these 7, I hope now you might get an idea. Don't pay lip service. You're not the hero. Sell the sizzle. Align the stakeholders. Watch out for perverse incentives. And don't make the mistake of applying technical solutions to adaptive challenges. And on that note, I will stop. Thank you so much.
Okay. Sorry for that. It's a lot of information.
If I had time, I would have gone through that.
Wow, fantastic. Thank you again. So thank you so much, Julie, for setting up the panel, and thank you very much, everyone, for being here. I'm Dr. Anna Grossman. I'm reader in innovation and entrepreneurship, so I'm giving you an academic side of things. And I will be talking about, actually, what I do for research is examining what Hassan is doing. So I'm looking at the effectiveness of governments around the world, especially with regards to digital health. And today I will present a paper that's been nominated for Best Paper at the Academy of Management. And this is common work with colleagues from Sorbonne University. What we do in this paper is we look at contact tracing technologies around the world, and we try to understand, because now after 2 years of COVID, we have some data, we try to understand what made some of these contact tracing technologies more successful in some countries than others. So we're really interested in knowing, why places like Singapore managed to curb the pandemic and other countries like the UK were less successful. So, and this is, of course, a phenomenon that, this is something that will live with us throughout the future years. Now we are moving to monkeypox, and so definitely these kind of technologies are there to stay. So what is the phenomenon that I'm studying in this paper? It's about contact tracing technologies, and the first one was launched in China, and that followed by the Singapore's Trace Together. So I don't know if some of you are coming from China or Singapore and you have experienced this, but essentially some countries adopted very stringent approaches, so you weren't allowed to go to public space without registering your data access. And so we look at around 50 countries around the world to see what determined their success in the penetration rate of those digital health technologies. And as you can imagine, this was very important for the governments to be successful, because this was before the launch of the vaccine. So it was the only way to prevent the spread of the virus. So, of course, so when we start digging into the data, we realized that these things were not without controversy. Singapore was successful, but at the same time, what they did was essentially passing on the private data to be used for either other purposes than controlling the spread of the pandemic. And this data, for example, became available to the police to track the individuals. So you can see that while Singapore adopted this sort of coercive approach and were successful, at the same time it was at the detriment of people's rights, privacy rights. In the UK also was a focus on privacy. Originally, the first app wasn't very good in terms of privacy because the collection of the data came first. And so there was a lot of concern with MPs, and the app had to be redesigned. And in fact, the UK spent quite a lot of money on contact tracing technologies. We're talking similar amount of money, we're talking billions, and probably did not get everything right from the first place. But we reversed in the UK to an approach which really took care of privacy in this sort of second launch. So what we realized when we looked at the data, and this is also related to my other work that I do on the role of state in the economy, we realized that the way the government intervenes in the economy is really similar to the way the government adopted this policy towards contact tracing technology. So if you are from a state capitalist country, and you can see on the very right, these are the countries such as China, Malaysia, Turkey, Singapore, Qatar, you would be maybe more coercive. So the role of the government in the economy, in business, is very high. So there is a lot of involvement, and this was also transferred to the way the government wanted to manage people's data, and the rhetoric of the government was more coercive, as opposed to other countries which are more democratic, and these countries were adopting, a more liberal approach, and what we see from the results were less successful as a result in the diffusion of these technologies. So you can kind of see a little bit the story. People do pay attention to privacy these days. So if you are designing, and this applies not just to eGov, but if you are designing digital health app, you really have to be careful about privacy. Because what we find with this large data set on 50 countries is that people do pay attention to privacy. So we have a privacy index where we look at the way the data was stored, used, end-to-end anonymization, whether the data was centralized or decentralized. So countries that score high in terms of privacy, and you can see them on the top of the chart, such as Germany, Portugal, Estonia, Finland, were also more successful in the diffusion of these contact tracing technologies. So this is something that we can take away for any digital health app. And countries scoring low in privacy were less successful. Finally, what we find is that, generally speaking, if you live in a society where people trust each other, there is a higher appetite for collective action. And therefore, people would also do things better or abide by the rules in a better way. And this is why we saw also that in countries where, such as Finland, for example, where citizens believe that they can deal with each other in a good way, they can trust their neighbors, there was also a better adoption of digital technologies around the COVID times. At the same time, in the UK, I don't know why, but the general trust, and that translates in trust into government, is quite low. And therefore, the adoption of digital technologies that are designed by the governments is quite low. So we need to work, even in democratic countries, we need to work on trust so that people can trust the government in case of future pandemics. And so, this is what we find. And it would be interesting to know also what you think, how the governments can learn from this crisis in terms of rolling out future digital technologies. So we find that there are different signals that can contribute to the success of digital technologies in healthcare, and the mechanisms deployed by the governments relate to their institutional foundations, whether these governments have more of a state capitalism background or are more democratic. So this is it. Thank you so much. And I look forward to the panel and the Q&A discussion. Thank you.
Thanks so much, Anna. Hi, everyone. I'm Lara Mott. I'm the CEO and co-founder of ImproveWell, and I'm so happy to be here with you today. So thank you very much, Judy, for the kind invitation. So ImproveWell was founded back in 2016, and our mission is to harness the innovation across what we believe to be the NHS's most valuable asset, its workforce of 1.7 million people, to improve the way that health and care is delivered. It's been a phenomenal journey over the last 6 years, not least in the last 2 years. We were really proud to be able to support the frontline's response to the pandemic. And I'm pleased to say that we've received lots of recognition in the last 18 months, which has positioned us as the leading digital engagement solution for improvement in health and care. So I just want to take this opportunity to give you a little bit of insight as to what my life has been like over the last 6 years. And in Hassan's style, I'll leave this picture here for you to picture. So this image is the epitome of what ImproveWell was like in the early days. And I promise you, we do actually have an office now, so we don't take our calls from the pavements. But I wanted to summarise the 10 challenges that I've faced as a founder innovating in and with the NHS. So the first one is building an app with no cash. There are lots of different ways to approach this. Some entrepreneurs may have had successes from previous ventures, so they may be able to invest money in actually building the technology. Some organisations partner up with investors from the get-go. We actually applied for a grant. So we looked at the evidence base. I co-founded the business with Dr. Naeem Ahmed, who's a school friend of mine, and he's very, very close to the problem. So we applied for a grant at Guy's and St Thomas's charity to build the app and run a trial with junior doctors. And we took it from there, really. The second big challenge is persuading customer number one to buy your great solution. And this is really tricky because you don't have the evidence base. So why on earth would they try your app over something else? So the way that we approach this, and there's a common theme here, is obviously building that evidence base from the environment, from the publications that are already out there. So our app was based on the Keogh Review and the Berwick Report, which were published in 2013, which concluded, amongst many things, that you've got to find a way to give the frontline a voice. They are the ones closest to the patients, so they are the ones best placed to be champions for change. So we needed to find a way to capture that innovation. And you will find research coming out year on year to back up your solution. So again, that's a common theme that's already been discussed. Number 3 is a big one. You know, if you're asking the NHS to essentially invest in your product, you're probably not in a position to give it away for free, or at least even if you do in the first instance, that's got to stop at some point. How do you do that? You know, when you know that the NHS is under so much pressure, and of course, arguing the business case, arguing the value proposition is really important, as Hassan's mentioned, but this is also about people. So what problem are you solving for that individual? And sometimes it's as simple as that. How can you make that person's life easier? And that's something that you continually have to do. So it's not just, you know, when you start off, you've got to do that in every new conversation you're having. And unfortunately, there isn't a cookie cutter approach to this. So it's a continuous process. Number 4 is then, you know, hiring someone to help you. So I was a kind of solo founder for the first couple of years. There were various other challenges, like having to build an app and not being a technical founder. I'm a scientist by training, so I was running an outsourced tech team, which had its challenges. But then you've got to convince somebody to come along and join you on the journey, and you've got no way of guaranteeing paying them beyond, you know, 2 months. So you've got to sell to them as well, and this comes back to Hassan's point about the stakeholders. You're selling to to your team as well. You're trying to get people to come along on that journey with you. And of course, you can offer incentives like perhaps owning part of the company or flexible working, join me part-time, have another job in the, at the same time. So you can have innovative approaches to how you build and scale your team. Obviously, in this day and age now, remote working has been fully embraced, which is excellent. So that offers up a wide range of opportunities for people to perhaps work in different time zones and that sort of thing. But it is challenging to get that first employee to come and join you and believe in you. Number 5 is co-designing with customers. So our platform has been designed completely, by our customers. Every single feature that you see in the tool has come from the very people using it, which sounds wonderful, but it's also fraught with challenges. So you have to strike a balance between listening to that customer feedback, but not taking on all the risk and perhaps building something that they might think solves their problems right now, but in a year's time, oh, actually, nobody's using it, or they got that a little bit wrong. So we always come back to the evidence base and making data-driven decisions, and it's one of our core values. But it's a very fine balance between making sure you're listening to the customer, but also evaluating that this tool can't become all things to all people. You may or may not have heard a phrase, I'm sure Hassan has, of there's more pilots in the NHS than British Airways. It's really tricky to move from that pilot phase to, no, we don't do pilots anymore. And actually, sometimes this can just be a language thing. So in the beginning, we offered pilots, we offered very flexible ways for people to try our tool without the risk of committing to something, organisation-wide for 3 years or whatever it might be. What we have now is what is called a land and expand strategy, which, you start small and then you scale up. But you have to get to a certain point where you feel confident enough to say, well, actually, we recommend you start here and then we recommend you scale up. And that could just be, it could just come with maturity of the business and having the evidence base. But it's a very difficult hurdle to get over as an innovator with the NHS, is moving from that pilot phase to actually, if you really want success, particularly in our field, which is engagement and changing cultures, that doesn't really happen in 12 weeks. You do need to take a kind of long-term view and go for 2 or 3 years, for example. And then we come on to the Dragon's Den bit, so the investment. At some point, you may choose to get investment to expedite your growth quicker than perhaps generating your own revenues can. And this is really challenging. So when you are a first-time founder, you're a female CEO, you've got no track record, there are a huge amount of challenges that you face, which I'd be happy to share later on in the Q&A. And again, it comes back to building that evidence base as you go. You will kiss a lot of frogs with the investors, but there will be some that you find that really share in your vision and can see what you've built and how you've built it. But then you have to argue valuation at that point. So how do you get the valuation that you want without the necessary revenue multiples? So if I had £1 million of annual recurring revenue, I probably wouldn't need the investment in the first place. So it's a real chicken and egg situation and something that just takes time. And ideally, you want to get yourself into a position where you can choose the investors that you're partnering up with, because they are going into business with you. So you really want to try and find like-minded individuals. Number 9 is explain why it's taking so long. We're not the Uber for healthcare or, the Deliveroo. This has been a 6-year journey. We've seen huge growth, and for me, it feels like it's going really, really fast. But to others, 6 years feels like a long time. So it's a really interesting place to be, to sort of try and benchmark yourself when you're doing something new with perhaps no like-for-like comparables. So that's certainly been something that we've had to juggle along the way. And the last one is proving return on investment when, as Hassan has said, NHS organisations are so different. So what works for an acute trust in London might not necessarily work for a mental health trust in Scotland. So you are constantly having to make sure that you are adapting your pitch and selling to different stakeholders all the time. So don't let me put you off. We have obviously enjoyed a great journey. We've been through, I suppose, what might be seen as the typical phases, so moving from a beta product with the pilots and the analysis and the customer feedback to confirming that product market fit and scaling up. The sales and marketing phase then came, so moving away from can I just sell this, are people just buying it from me because I'm a nice person and I'm very passionate about my product, can we sell this regularly and move towards a more predictable revenue model. We've then been very lucky to have had a lot of recognition. You can see on the right here my customer Zoe, who won an innovation award for her maternity department, which was wonderful to see. And now we're in a stage where we are working with partners to be the digital partner of choice for the services that they're offering the NHS, which is fantastic. And from a scaling the product perspective, this tool has gone from supporting local initiatives, so supporting our partner East London NHS Foundation Trust on their Joy in Work initiative, through to working with the Royal College of Psychiatrists, who have rolled that out nationally. And the Institute of Healthcare Improvement in the US also took that model and rolled that out internationally. So it's been amazing. If somebody told me that I had to achieve this all in 6 years, I probably wouldn't have taken the job. But it's been amazing just taking each step every week, which brings me nicely onto my summary takeaways. So the top 3 things I would say is delight the customer. We wouldn't be where we are without our amazing partner organisations. We work really closely with them and we're always listening. We make data-driven decisions, and sometimes those are tough calls to make, but we always come back to, as Hassan has mentioned, what problem are we solving? Do we really understand the problem? And then this is our secret sauce, which I'm happy to share. We take small steps every single week. So the entire team embraces this philosophy, which is every week on a Monday morning, we tell the whole team what 3 things we have to do this week, what 3 things would be really nice to do, and we look back at the previous week and we decide what 3 things we should really stop doing. And so we bring that culture of continuous improvement to what we are already doing and what we're selling to the customer. So thank you very much for this opportunity. Please do connect with me. It's a bit fiddly.
Okay. Yeah. Hi everyone, thank you very much for the invitation. So I'm Lloyd Price, co-founder and CEO of Hive Health. Today I really wanted to share the lessons that I've learned in the last 10 years of working in digital health. Been working for technology companies for about 22, 23 years. The sort of first half of my career was more consumer. Worked at the first price comparison site called Kelku. We then got bought by Yahoo 2004, and then worked for Yahoo till about 2010. And then I went into the crazy world of dating, worked for a company called Badoo that became Bumble, and a big success. So first thing I'll say is healthcare is tough, man, compared to other industries. I think this is the 6th industry I've worked in. Boy, you've got to love this. You have got to chip away every day. Okay, there are a lot of blockers. A lot of people don't want you here. I'll be honest, they don't want us here. Okay, it's a very incumbent-driven industry. I call it like defense and aerospace and massive global incumbents. So your solution can't be twice as good, it's got to be 10 times as good to chip away and get in through the door. So yeah, I feel quite privileged. Yeah, we started out in 2012 with Zesty Consumer, very much online booking, scheduling. We did a big pivot in 2015, very much listening to the market. Started to focus on integrated care, very much for the NHS. And then last year, started again, looking more at cybersecurity. So really, the lessons I've learned founding 3 companies and then sort of being a non-exec in different bits and bobs. So Zesty, we really followed the whole B2C. You know, we really believed that direct to consumer. We really believed that you could build the product. We really believed that we could build the app. We really believed if we signed up thousands of dentists, doctors, physiotherapists, we wanted to solve the problem of access to healthcare. So we felt back in 2012, James and I, that we were convinced there was this hidden supply of appointments. We were convinced that there was a lot of supply, and we were convinced we could get that through API integrations into the PMS systems, coming from our background and our world, you know, having seen things. A good example is probably the travel industry. So at Yahoo, what we saw was 4 big GDS, global distribution systems, start to develop: Amadeus, Sabre. Google bought one of them, and really all the airlines, their entire systems are built off global distribution systems. So we started to think, could we become the middle layer and connect doctors and patients? We got quite lucky, if I'm honest, to Laura's point with the investors. So we flew out to Luxembourg. We met with Mangrove Capital, who invested in Skype and Wix. And we said we wanted to build basically this model across Europe. I think we had 5 or 6 slides. But the massive first lesson I learned is that they only invested in us because half of the pitch deck was about the risk. We literally said, this is the risk in the next 2 or 3 years, and hopefully this is how we can overcome the risk. So to be honest, halfway through the pitch, they didn't really listen that much. Then at the end of the pitch, they said, okay, cool, here's $1 million, go incorporate the company, let's go, because you're so clear and sort of a bit more mature and a bit more grown up that there's going to be a lot of problems along the way, but we're getting a bit tired of entrepreneurs running in saying, we're going to take over the world and we're going to do everything. We want people a bit more grounded because this is tough. And the other thing they said to us is we want street fighters, people that will fight on the streets, that won't give up, kind of French Revolution style. They said that's what we want. They said, I think technology is too overlooked. So built it up, Series A, $7.2 million, brought in Qualcomm Ventures and a few others. But the other thing I'll say is, then this stuff gets real. Okay, there's a lot of expectation. You've got to grow fast. My experience of working with VCs and investors, it compresses time. You sort of think you have all this time, but you just don't. You know, you increase the burn, you hire more people, and then all of a sudden your run rate just goes from 24 months to kind of 20 months. You're convinced the next 2 big key hires are going to solve the problem, and then all of a sudden you're down to like 14 months. It takes like 6 months to raise money, so really you've got 8 months to turn the ship around, and you're like, how have we got to this position? So definitely, maybe you can talk about that slightly later on. So 2015, big kind of pivot. Big lesson that we learned is a lot of people in the NHS were saying, oh, I used your app to book a dentist, to book a physio. Oh, you know, my wife used it to get an emergency kind of treatment. So I think that one lesson we learned is you start in health going down one road, but you then kind of veer off. And quite often people pull you in. So it's not push, it's kind of pull you in. Another big break we had was Joe Harrison. We met Joe Harrison at the McKinsey event in the Ice Bar in Stockholm. And he said, can you come and build this technology for outpatients in my hospital? And James and I are like, yeah, sure, no problem. He's like, you know, we work with Cerner. We'd never even heard of Cerner. If you'd asked us, we didn't even know who they were. And we just sort of blasé attitude of, well, how hard can this be? So I think Joe kind of bought into that pseudo-fake confidence. And then it all got a bit real. We were suddenly in front of, clinicians, kind of IT managers. And I think a little bit like Hassan and Lara have touched on, healthcare is a team sport, multi-stakeholder. You have to convince a lot of people. Another big lesson I've learned is it's not about getting a yes, it's making sure you don't get a no. Because the clinicians, the tech guys, the CFO, the kind of data governance, IG teams, there's a lot of people. Healthcare, in my opinion, is very democratic. We all sort of hold hands, sing Kumbaya, and dance around the fire. If there's a consensus, it's a good idea. It kind of happens. 1 or 2 people don't like it. It's not going to happen. So I think really think about. You've got to really, convince quite a lot of people. Moving on to today. So a year ago, I sat down with Glenn from the Royal Free. And he's like, Lloyd, we've got a big problem in cybersecurity. Like, we've got a big problem with medical devices. So I was like, okay, but do you just have the problem, or does everybody have the problem? So we then basically spent 6 months doing about 40 in-depth interviews with customers, and we just kind of immersed ourselves into the world. We wanted to understand their perspective. We kind of got a bit obsessed with kind of user profiles. We just wanted to keep hearing the story over and over and over again. Like, what is your problem? What is your problem? On top of that, I did a lot of sort of desktop research, a lot of academic papers. There was something what I call the Korean model, which was a very, very good paper on the sort of the problems. And then I think you start to realize that kind of academia, business, and sort of healthcare, you start to realize they're all fairly entwined. And I think the trick is you've got to sort of pull the best from each. You know, there is very good world-class research. People have got a lot of theories. Business people are saying, well, if you could do that, that unlocks that funding stream, you could deploy that. And then healthcare are like, that is our problem. If you can solve that problem for us, that's really going to help. So moving on to sort of key lessons, really. In my opinion, people, processes, and technology, you have to do all three. So people, the biggest blocker to change. People just don't like you. They just, I don't know what it is. Sometimes it's just a personality clash. We'd walk into meetings in 2012 and they'd say, which one's the doctor? And we'd say, is somebody sick? Or we're here to help with the tech, not to sort of save lives. Then we met some surgeons. Then we met a lot of academic people. And there was just a lot of, why are you here? Who are you? You don't deserve to be here. So I think that's another sort of thing we had. I think that's changed. I think 2012, if I'm honest, but yeah, 10 years ago, it was quantified self movement. People like Ali and Babylon just started to launch. There kind of wasn't really anything. And I think they just saw us as blaggers coming in from other industries, just talking a big game. I think another key lesson, don't even think about deploying the technology until you understand completely all the processes and all the people. Don't even think about designing the product. Don't start with your blockchain and your distributed ledger and any cool funky tech you think. It's not going to impress them. What's going to impress them is you solve my problem today. I'm not interested in 6 months when your machine learning algorithm is going to get a consensus score of 85 and be approved by NICE. Can you help us today? One quick example, one of our first big clients was guys in St. Tommy's. We deployed some technology, and then we heard that they weren't using it. So I basically just went and sat with a lot of the nurses, and they're like, oh yeah, we don't really use this. And I sort of said, oh, why not? And then they just showed us one or two incredibly simple things, features that they found difficult to use, sat with them, learnt it, unblocked that kind of problem, which very much was a people problem. And then suddenly we got recommended, and before we knew it, we were across 70 specialties and guys in St. Tommy's, all because we solved the people problem. We didn't solve the tech kind of problem. Number 2, hearts, minds, and egos. I think this is very, very important. You've got to understand whose hearts and minds you've got to win over and whose ego you've got to manage. You could have an ambitious CEO. Then you get the practical COO. Then you get the super ambitious CCIO. And then you get the kind of, very strict kind of clinicians and maybe nurses and then maybe financial people. So you've really got to kind of understand, again, multi-stakeholders. I believe what we're selling is change, not innovation. So I know Hassan very beautifully described it. Big Peter Drucker fan as well myself. But I think what I've learned is that what we're actually trying to do is win hearts and minds, get the people on board, that we can start to enable the change, then totally understand through our processes, pathways, the rules, how that will work. Another good example, at Milton Keynes, we were quite lucky in that we became the first people to integrate actually into Cerner bidirectional. And everyone thought that was the secret sauce, but it wasn't. The secret sauce is that we sat down painfully with 40 of their team to understand all the rules for every outpatient specialty without the kind of middle piece. The kind of cool app and the hard back-end bidirectional integration into the clinical systems wouldn't have worked. So quite often I think, you've got to really understand all the different kind of pieces to it. Brings me on to what I call the 3 ships. Relationships, friendships, and partnerships. You need to build relationships with people. You need people fighting your corner. Okay? You need someone in the boardroom and somebody walking around the wards. Those 2 stakeholders, ambassadors, have got to say, we need to do this, I want to do this. It is so easy to say no. It is just so easy to block it. It is just so easy to say, but we use EMIS, we use this, we use, like I said before, you don't have to be twice as good, you really got to be 10 times as good. And along the way, you build a lot of relationships, and that's the key as well, because in our experience, we grew through word of mouth. We grew because people adopted it. We grew really because people trusted us. You develop friendships. People give you advice. I think 2 or 3 times I can think of people have come to us and said, yeah, but Lloyd, you really want to be doing this, mate, because that's the kind of next bit. And I think a good example of that, 2016 virtual wards. We started to hear, yeah, but Lloyd, all the action's going to be, out of hospital. Start thinking not just about in clinic, but out of hospital. And that was because, we had sort of friends and people that wanted to work with us. Partnerships. To scale, it is very difficult going one-to-one. You need to go one-to-many. So I definitely think a lot about partnerships, invest a lot of your time. We ended up doing a deal with Cerner where we actually became a strategic partner. Only the second deal they did Nuance, which got bought by Microsoft, and then they did us. That took me 3.5 years to do that deal. Continuously knocking on the door, continuously working with other people, and then deciding, right, let's give it one last shot. And then we kind of went, and then they just said, the timing is now right. Quite often, timing is very important in innovation, I think. We can run in and think they want it now. They don't really want it, right now. And then what I call the fear framework, just because so many people ask, what do you think it takes to be successful in digital health? Funding, we've touched on it a lot. You need money. You need to get going. You need to hire staff. You need to develop the product. You need to hire healthcare economists. You need to travel. You need to stay and go to conferences. Evidence. I think the next wave of digital health is going to be less about sexy design and Apple and everything, and it's just going to come super back to basics, like clinical, operational, and kind of ROI models. Show me the evidence that this works. Show me the evidence that people adopt this. Another piece I think that everyone forgets about is simply awareness. Healthcare, in my opinion, and particularly I think in the UK now, it's a very attention-seeking market. People throw up big numbers, they're in lots of conferences, they speak a lot. And then there's almost like this miseducation in the market. People think that, the product does this, it doesn't quite do that. There's this sort of belief that, they're the market leader when they're not. There's a lot of what I call vaporware. There's stuff out there that is supposedly software, but it isn't. It hasn't been tested, it hasn't been deployed, it doesn't integrate into anything. It's like, well, what is this? It's got a really flashy website, but kind of nothing else. And then lastly, revenue as well. You need to find a business model that works coherently with healthcare. I think Hassan touched on it earlier about the perverse incentives. I think that's very, very true. One good example, when we sort of went on the journey with Milton Keynes, a lot of the technology we did was saving people, processes, and paper. It was saving a lot of paper. You could reschedule your appointment online, and it started to cut down the number of people they needed. We weren't very popular. Suddenly, it was this patients could self-serve, whereas the NHS likes to protect the workforce. They like to kind of protect, all the people. And then lastly, I think, what advice would I give myself in 2012, and what advice would I give to you guys today in 2022? This is a long-term journey. It takes a decade, really, to have the impact you want. 7 to 10 years. If I think now, standing with people like Ali Parsa from Babylon, 2012, Medopad, Touch Surgery, Current Health, all billion-dollar businesses, it took them quite a long time. We touched on it before, passion. You have to get out of bed and love this as much as your children. You have to really believe it. People, missionaries, not mercenaries. I actually stole that from the team the other day because someone said it to me. He said, Lloyd, we want to hire more missionaries, not mercenaries. Let's stop paying big salaries and really get people, spreading the word. Research, stick close to your customer, stick close to the users. I think Hassan touched on it earlier. You have 2 customers in healthcare. You have your user and then you have your buyer. They're 2 very different people. And then lastly, get ready for the second wave. You have to prove value, you have to prove adoption, and you need a ton of evidence. Don't bother with pilots, as in don't walk in there and just sort of convince them with a pilot. You have to convince them with the value you're going to unlock, and what problem you're going to solve today. So yeah, thank you very much.
everyone. So I'm Leonid. So my journey is a little bit different. I did medicine in the States and then came over to Oxford, did a DPhil in medical imaging, and then decided to lead medicine and join a consultancy. So I joined McKinsey for a while, did some work in their healthcare practice as well as their private equity practice. And then about 20 years ago, left and started my own consultancy focused on healthcare and consulting. That company is Candesic, and we, about 30 of us, headquartered in London, a third of us doctors, but working with a lot of investors, as well as operating companies, healthcare companies, pharma companies, hospitals, across all areas of healthcare. And in digital health, we've done a lot in software across primary care, social care, secondary care, as well as digital health, more patient-facing services like virtual consultation businesses. I think some of the businesses that have been mentioned today are probably on here as well. So that's kind of my background. What I thought I'd spend today talking about is one of the innovations that we've seen explode since the pandemic, which is virtual consultations, and also talk about some of the other digitization that's happening in healthcare that's really been accelerated by the pandemic. I thought I'd show this slide to show the difference in adoption of digital health and virtual consultations across Europe. Sweden, Holland, very high adoption rates, where I think countries like Italy and Spain, very low, and Germany, very low. The main, and the UK is somewhere in the middle, the main reason for this has been reimbursement. This is another one of these, it's not that Sweden is particularly more tech savvy. In Sweden, they've always reimbursed consultations based on having a consultation with a doctor. You didn't physically need to be at a clinic. In Germany, for example, a doctor who did a virtual consultation wasn't paid. That was the rules. And UK was slightly in the middle, where they were given money for, they're paid on a, GPs are paid on a capitated basis, so they're given a block sum of money to look after their patients. It's then up to the GP how they look after them. So the UK is actually one of the higher adoption countries. If we look at what happened pre and post pandemic, the UK had about 15% consultations, primary care consultations, being virtual. And then that more than doubled during the first lockdown. A lot of these consultations were telephone consultations, and of course, as the technology became available, a lot of those moved to video consultations, and now they're mainly video consultations. Looking at other European countries, it's hardly anything in France or anything in Germany, and even during the pandemic, in the middle of the pandemic, it still wasn't being done because mainly of these blocks. This is some of our estimates, just to say where are we going to land. Probably about a third of consultations in the UK will be virtual in the next 5 years or so. Germany's got to sort themselves out. They are changing the rules this year. It's going to grow probably a bit slower to maybe 8, France maybe 15. US is around 20 at the moment. So UK is doing pretty well in the digital health space. As consultants, we like to segment everything, and this is our version of what a virtual consultation looks like. So you have things that you need to do as a patient to prevent disease. Then if you do have a problem, you need to search to find a doctor. Then the doctor needs to figure out how important it is to see you. Then you need to book a consultation. Then you need to have the consultation. You might need to capture some vital signs, might need to do some tests. You might get some prescriptions from that, or be referred to a specialist. And then you have to monitor how you're doing, especially if you have a chronic disease. And then hopefully post-consultation, engage with the patient to make sure that they look after their health. And across all of this, you need some practice management software to kind of glue it all together. We look at some of the companies that have been doing things in this area. So we look at the kind of the pre-consultation phase of doctor search, triage, and booking. This is companies in France, Germany, and Spain, startup companies in the practice management, the online booking, and general tech platforms. Huge amount in France. This is a very competitive area, and many of these companies won't be around in a few years' time, I can guarantee you. A lot of these guys started with scheduling, because that's a very common thing that you need, and they've moved into things like billing, prescriptions, medical records, offering telehealth, and so on. I thought I'd just mention Dr. Lib, which is wanted to say something about innovation. Anybody heard of Top Table? Anybody book restaurants? Top Table, yeah? Yeah. So what Dr. Lieb did with healthcare is what Top Tables did with restaurants. For those of you who don't know Top Table, they put software, they gave software to restaurants to help manage their tables and their reservations. But they also built a website that communicated directly with that software was sitting, it was all cloud-based, of course. And so their website had a full visibility of all of the availability of tables in that restaurant. And it would, if someone booked a table on the website, it would immediately pop in as that table has been booked. Don't put anybody there on the restaurant system. So it's revolutionary. Before everyone had either did it on paper or had little systems that didn't talk to anything. But Top Table created this site which restaurants then bought because they were using Top Table as a way of getting customers. So in addition to walk-ins and people calling up, they got a huge amount coming from Top Table, which was a kind of a clearinghouse of all restaurant empty tables in the city. Dr. Lib did exactly the same thing with patients, with doctors. So doctors would have their schedule. I can see 10 patients today, so I've got my schedule, whatever. And they would use Dr. Lib to. Dr. Lib had a website, and you could go on and you could find a slot at this doctor, at this clinic, whatever, in the specialty, and book it right there, and you got it, and it went directly into his calendar. So doctors bought it like crazy because they suddenly got a lot of extra work coming from Dr. Lib, in addition to the work they had in their clinic. But very innovative, and I think the innovation there was taking something that was successful in one industry and applying it to healthcare. As tough as that is, with healthcare being so a difficult sector like defense. If you look at the actual consultation, we've talked about Babylon. There's other players, different countries. Again, they're all moving from kind of core consultation services into things like preventative healthcare, remote testing, vital signs capture. So they're kind of spreading that way. There's also a bunch of players that offer just the tech stack. So these guys provide doctors and technology. These guys just provide the technology. So the doctors are provided by the NHS or by whatever organization they sell the service into. So, and there's a lot of these. Babylon we talked about, they're doing something clever with adding AI to their thing. It hasn't really been done yet. It's all a bit of hot air still. Their share price is kind of showing that as well at the moment. But great vision, and at some point they'll be successful. They're doing great, but this is probably a few years away. There are other companies like Health Hero who have started off as one company, Medical Solutions, acquired number ones in other countries, and then also started going into prescriptions, triage. So they're diversifying both geographically and in terms of what they do. You've got Livy, started in Sweden, went to Norway, went to Spain, got lots of funding, raised huge amounts of money over time, and now are pan-European. And some of the interesting companies that are doing health tech stuff, they're democratizing health by using the camera on your phone to be able to take vital signs. So they actually can sense the flushing in your skin from your heartbeat and measure your heart rate, for example. So anyone with a phone, the doctor can get data remotely. You've got cameras and skin, look at moles. For the dermatologist, you virtually don't need to see the doctor anymore. It's all can be done virtually. You've got wearables that measure. You can now get a 12-lead EKG by putting a special vest on, and you can get the same diagnostics as you get with lots of wires connected to you at a cardiology consultation. And patient engagement is very important to get people with long-term conditions to get more looking after their own health. Home diagnostics, thought I'd mention this as well. There are a number of companies now offering tests. So any test you could get at a doctor's office, you can now order in. And this could be anything from getting your cholesterol checked to testing for hormones and various other things. So there's a lot of, and just pay it out of your own pocket, get it sent in the post. A lot of people don't like needle pricks or don't like finger pricks. So there's even a company called Tesso, which has made a little vampire device, which you get this in the post as well. You just take it, you stick it on your arm, you push a button, and it just sucks the blood out of you. And it's not that bad, really, but it's painless, actually. It uses a very small needle, takes a few minutes, but it literally just collects the blood. You take the tube out, send it off, and then you get your results back. So really making it easy for patients and people to get tested. So I thought I'd finish with saying what health is going to be like in 20 years. One big problem that a lot of startups have is trying to own the patient. Everyone and their dog wants to own you. They want to have that relationship with you. So you go out and you buy, I don't know, a wearable, and Polar or Garmin, whatever, will have a Garmin app and the Garmin website, and they'll try to suck you into the Garmin ecosystem to do everything Garmin. Apple, of course, is probably one of the biggest examples of this. But you have companies that do pharmacy, that they want to be the pharmacy that people deliver you the medication. Amazon, to have all of these people that are trying to own you or own the relationship with you. But as an individual, you only have a certain amount of time in your life. You don't want to have 10 different relationships with 10 different healthcare verticals offering one thing or the other, either monitoring or drugs or something else. So there needs to be someone in the middle, like a health navigator, that pulls data and information from all of the things, from your wearables, from your doctor's record, from your prescription history, from your medical records, and then guides you to what is next, analyzes information and tells you need to go to this doctor, or you need to take it easy today because your heart rate's too high or whatever. And that holy grail is what everyone's trying to get to, and the most successful tech companies will be that. And that's kind of like Alphabet's there, Apple's there. Everybody's trying to gun for that. Babylon's there as well, and they're trying to do that. But there's only going to be a couple of winners there. And finally, kind of our predictions for how health will change. So in prevention, we're going to see a move from, this is kind of our thinking of how things are going to change going forward. We're going to see a move from people having to go see a doctor because something's wrong with them, to actually looking after their wellness from a more preventative way and proactively seek advice before they have a problem. We're going to move from, in terms of investigations, we're going to move from point diagnostics that are done by a doctor or nurse when you visit, often on your after your first consultation, to a lot of point of care work where you get diagnostics at the consultation, so you don't need to come back for results. We're going to see things moving away from doctors doing everything to having a split of work between doctors and physician assistants. So by using tech and some automation, we can let non-doctor physician assistants do some of the work that doctors do. And actually, that's the only way we're really going to solve the problem of the huge healthcare burden that we have and limited number of doctors. We're going to have specialist investigations done in specialist centers by specialists, to having technology solutions being available to everyone, and again, physician assistants to be able to do some of these specialist things. Because before, to operate this device, you had to be trained, and there's only a small number of people that could do it. In a digital automated system, you can now operate this device remotely, and all you need is a nurse to help that patient, plug in or whatever. treatment. We're going to move from a lot of the heavy stuff being done in secondary and tertiary care facilities to a lot of it being done locally, even not in hospitals. It'll be in the community and closer to where the patient lives. And data and monitoring is going to move from stuff done by doctors, oftentimes in hospitals or clinics, to being done at home. So, and consumers being fully aware of the data that they create and how their health is progressing, because all that data is going to be available to them and to their doctors. So we'll see if that happens. That's my details. Thank you very much for your time, and feel free to give me a shout.
Oh, that's great. Where do we begin? So I'd like to invite our panel members to come and sit up here, if that's okay, because we are live streaming, so we'll take a break afterwards. But do help yourselves some water as we go, or beverages. So I think it was a very interesting ending to look to the futures there. So now over to the audience. Any questions, comments, tips, advice? We had kicked off with Hassan, then we went to Anna, Laura, Lloyd, and Leonid. Yes.
I'll start with the question.
Go ahead, thank you. This is for
So I think that was fantastic. So first of all, I'd just like to thank all the speakers. It was really interesting. But I just recently read this stat that said that most innovation actually never gets embedded into health systems. And that actually for all the innovation that never makes it, we could probably take care of all of our aging population. So, and then moreover, you know, even good ideas can often take 17 and sometimes up to 30 years before they really penetrate a health system, let alone think about between health systems. So could you share with me, you know, I don't know if all of you want to answer it, but what do you think are the kind of key things for translating innovation into health and health systems?
Whoever gets the mic first, go ahead.
Can everyone hear me here? Is this working? Thank you, Nora. I think translation in the space that we're talking about has a couple of steps. The first is getting out of the lab. And I don't think that's where the challenge is. I think the challenge is trying to find the real-world evidence that you can take it into a real environment so that you can place it in the hands of physicians, put it in the workflow, and use it in anger, if you like, with patients. And that's where we don't do very well with that. We don't make the test beds available. We don't make the funding available. So the one problem you have is that if a hospital's going to do that kind of test bed work, they want to be paid because they're going to be taking their time to do it. But who's going to pay them? And that's where the problem, the innovator doesn't have the cash at that stage. So if we can accelerate the adoption of the right technology and get the funding there early, that's really important. And I think that falls on health systems. I think that falls on governments and their innovation agencies. And that is actually the role in the UK, in England specifically, of the Accelerated Access Collaborative, which is why they're trying to make that happen with the academic health science networks. But I don't think I see that everywhere else. And I don't think we do it perfectly either. But I do think it's government intervention, central intervention, to find the most promising interventions, get them the funding, get them the test bed, get them the evaluation. Otherwise, they will languish. That's my personal view.
Generally speaking, most startups fail, so this is a common phenomenon in different industries. So to start with, you know, not all ideas will materialize. In the UK, we have a really good research capacity, but then it gets lost in translation somehow. And I think it's about having collaborators and having these different elements that glue the different organizations together we mentioned today collaborators, enablers, and as data sources, as data becomes more complex, you need people who are understanding the different aspects of where the data is coming from to connect it all together. And I think the academics, industry, government collaborations are key. So we talk about triple helix models. So these are the sort of things that have been tested in innovation in many countries and in the UK as well. And I think the funding, as it is crucial, has to come to some extent from the government to facilitate the integration of the research into the real world.
Go ahead, Lara.
I'll just add something from I guess my perspective, which we see a lot, is looking after the people that are giving care. So if we can get everybody thinking innovatively and believing that it's their job to also improve rather than just leaving it to a certain few, then hopefully those culture of innovation and being able to make mistakes and learn from them, learn what not to do, that kind of thing, if we can instill that culture in everybody, then hopefully we will help to drive adoption, we will help to drive change. It's just a simple comment from my point of view.
Thank you. Yeah, embedding. Would you like to say something or ask another question? Right, anyone from the audience, another question? Feel free. Some of our students at the back who are incoming as students, anything you'd like to ask? You're doing a digital MSc with us, is that right?
Yep.
Yep. Okay. Any comments? Feel free to ask whatever comes to your mind.
Yes, I was thinking about the what is called Dr. Lib, and for me it's more like a two-sided platform, and I'm thinking about it. So if one side of the platform, like the doctors, are more and more in this platform, will the consumers or the patients turn to the only one platform, or will there be more platforms in this market or in this industry?
Let's take the example of Uber.
Yeah.
So once there was Uber, now there's like, no, this one, sorry. This one. Let's take the example of Uber. So once there was Uber, now there's 5 different platforms. I took a taxi from Stansted Airport at about 1 in the morning last night, not by choice. And he had a phone with 5 different apps. He was on Bolt, he was on Ola, he was on Free Now, he was on Uber, and some other ones I've never even heard of before. And you kind of wonder, well, there's so many. I mean, why choose one? Why not go with one? And he was like, well, they have different. Some are better at different times of the day. Some give you some more surge pricing. Some I can tell that I want to go back home because I live in East London, and they can send me that way. And not every platform meets everybody's needs. You do have Amazon, I guess, as a platform, and there's a certain eBay. There's a certain network effect that you get there, and that does exist in some areas of healthcare. But there are still other places to buy stuff than Amazon, and a particular platform is never going to appease everyone. And if anything, the way the world is going is to bring patients more choice into how they get healthcare, where they get healthcare, on what terms, when. It's Pride Month, so I got a Babylon GP at hand, which I'm a member of, a circular, and they said it was the race to get advertising LGBTQ plus doctors. So if you wanted to access a doctor who's friendly to the LGBTQ community and to deal with certain issues that community has, then you can go to Babylon and select that. Yeah. So these are just an example, but it's ways that you're creating platforms for very different cohorts and for different needs. I mean, you can already request a female doctor or a male doctor. You can do that. So there's a lot of, I think, scope for different types of platforms, and I think it's only going to get more broad to meet people's needs.
Yeah, thank you.
First, thank you to the panel for that excellent talk. My question is actually for Lloyd. You mentioned you started off with Zesty Health, and you said you were trying to solve the challenge, the age-old challenge of really matching supply with demand, the excess or surplus of doctor supply versus demand for healthcare.
Mm-hmm.
You also said you pivoted. So my question is, why did Zesty fail? That's that way.
No, it's a good question. So the original business model failed, which was direct to consumer, because what we realised was with the NHS, the propensity to pay beyond a certain percentage of the population. In some ways, yeah, the original model, direct to consumer, private healthcare, primary care, did fail. But interestingly, it actually led us into other industries. So, for example, Guy's and St Tommy's, we gave away the technology for sexual health. So the online booking was the first time you could just do direct access for sexual health. That actually led us to be part of a consortium that then won a £200 million pan-London contract. So I think, again, in healthcare, you don't have it all figured out straight away. You know, we had a vision. It was very consumery. You know, it was, you know, the Uber of healthcare, the Expedia of healthcare. So yeah, I think, yeah, good question. I think one side of the coin is it failed. The original vision and model failed. But on the flip side, it unlocked the confidence to take us to a different part of the healthcare industry. And I think
you've been very successful with your turnaround. Congratulations. But my next question would be really as a follow-on.
Sure.
Is what was your approach to the initial sort of markets when you were considering? Do you approach it as in there are multiple different specialties, or do you pick a certain specialty and try and expand in that?
So we did all the research, and we actually started with dentistry, because what we saw was there was the majority of the search, so on Google, the more searches for dentist near me, local dentistry, than any other healthcare specialty. So we thought, well, that's where a lot of the demand is. Then we looked at the geographical distribution of dentists, and we called it the Noah's Ark approach, 2 by 2 by 2. We wanted 2 dentists in every postcode in every part of London, Manchester, etc. So, and then we started to kind of think, well, how do you connect? The next part of it was we looked at sort of the application layer. We're like, okay, so the PMS systems, Exact and a few of the others, do they have open APIs? Can we get access to it? So I think what we did was we tried to look at it as a puzzle and understand what are the pieces that you need to connect patients with doctors. And in the middle, we need to build a platform. So what do you need for the platform to flourish? You need demand. You need supply, you need the actual technology. So where are we going to get the appointments from? The biggest other challenge in healthcare is the 2 screens. So they have the existing, you know, Cerner or EMIS or TPP, and then we introduced a second screen. So, you know, how did that work? And so I think the honest answer is trial and error, but keep chipping away every day and just keep talking to the customer. Stick as close as possible to the customer. Solve their problem. Don't solve the problem you think needs solving. Solve their problem. Yeah, pleasure.
Okay, great. Hassan, and then we have 3 questions online, and then we will have some time for networking. Yeah.
So I'll be very quick. I think there's bravery. This is a very general comment, not specific to this, but I think there's bravery in pivoting, and I think there's foolishness sometimes in not pivoting. I didn't write on my bio that I've had an exit because Lloyd's had so many, it just doesn't look so. But in my one exit, I think we pivoted 6 times in 9 years. And one of those pivots was in the first few months, right? You will come up with new information, you will find new things, and if you don't make the brave step to pivot, you may die. And I bootstrapped to exit. I didn't get any funding, just friends and family. Got to the very end. I think we shaved off 1% from the 3 founders to give golden handcuffs to our account director because she was holding about £1 million of revenue on her own. So we needed to make sure that there was nothing she wasn't going to go anywhere so that we could execute that sale. So for us to get to that point is rare. Most people have given away a lot of equity, they've been diluted. I got to that point knowing that I had to pivot, and we did it. And we had some tough times, but I commend anyone who does pivot.
Maybe to add a few points, it's important to innovate your business model so you can continue based on your capabilities, something new. I was looking recently at Randux. You know Randux, so they've been really successful with COVID testing, the home kit. And now, of course, this is slowing down, so they're expanding into adjacent areas of testing, for other symptoms. And so I think it's important to constantly innovate, taking opportunities. So.
Great. Can I give just the online questions? I know you have one as well. So we had two particular online ones. How can big pharma be patient-centric rather than just profit-centric? And what about the next pandemic, and how can we prepare and innovate for that? Any thoughts?
I've got thoughts on the pharma for sure.
Yeah.
Yeah. I think pharma are scared, and I use that word very carefully. I think they're scared of getting it wrong. So for a long time, they've been saying, we're not just about product. We want to be able to sell a solution. We want to be able to give patients therapies and be part of their lives and support them as a partner with the health system. So they didn't want to get that wrong. But in order to win, they actually have to be brave enough to take a risk. And the actual risk is going to be digital therapeutics combined with non-traditional. Maybe it would be a device. Maybe it will be collecting real-world evidence through an app alongside your drug, because no longer is the molecule enough.
Yeah.
So if you're going to do that, then you're going to get close enough to the patient to actually be patient-centric. But while you are focused on a molecule, and while you're worried about the digital side, I don't think you can truly be patient-centric. And that's the thing that pharma companies are now starting to come into. And I make a prediction that the companies that will do well in the next 10 to 15 years in pharma are those who embrace digital therapeutics, digital medicine, and get that bit right.
Great, thanks. And any future looking? Okay, go ahead.
So I thought I'd just add, just on the pharma side, at the risk of sounding overly capitalistic, so I apologize. I think we can never really hope to have pharma companies not think about money. At the end of the day, that money is what creates innovation. If it wasn't for potential for profit from drugs, pharma would not invest huge amounts of money into producing them. So I think that's important to understand. But I also think that the two are not mutually exclusive. I think you can make money as a pharma company and be patient-centric. And that we're seeing more of that happen now with areas, things like personalized medicine, in areas where the pharma companies are not just making a drug, but they're actually looking at how the outcome of the patient happens as a result of that drug. So it's not just about the drug itself and does the science work, but does the patient take it? Are they compliant? Do they follow protocol? Because half the time the drugs don't work, it's not because the drug doesn't work, it's because the patient doesn't take the drug properly or the way it's intended to. And it's not that they're doing it on purpose, it's just for whatever reason, they just don't take it in the way that it's intended. So now there's electronic pills now where you can take and your phone registers that you can actually take in the pill because it's electronic and it Bluetooth connects to, a lot of really cool innovation. So I think we are getting there, but I'm still, I think, a believer that the economic incentive has to be there. Otherwise, we won't have smart people. Many of you who will probably work in pharma have jobs that will do all that stuff. So.
Great, thank you. Anything about another pandemic? But I'll hand over to this question while you're thinking about that.
My question is about what do you think about success opportunities of healthcare innovation in emerging economic and developing countries, especially they are suffering from weak infrastructure, digital infrastructure, and high level of state control. So we talk about this is the future for healthcare. But in this situation, I think is it will be successful innovation or not? My question.
I'm happy to go for that if that's. So when it comes to countries which are perhaps less developed in their health systems, I think there's this view that they probably aren't as innovative when you look at how many publications the Americans are putting out. And the Americans put out lots and lots of papers about their innovation. And if you just looked at the publications, you'd think that the Americans are the most innovative and everyone else is way down the list. And actually, that isn't the case. It's just that there's an incentive, if you're in the American system, to be publishing about your innovation because you're trying to show that this is the shiniest system, come to us, do more with us. What I've found is frugal innovation. What I've found is people who are hacking the system. What I've found in countries that are perhaps, labelled less developed, to be far more innovative. And there is this a massive problem that we have in the UK and other countries of legacy and technical debt, where because you've got such a problem now, you have to patch over that piece of work with bloated technology to continue surviving. Whereas if you go to a country, and I'll give the example of Kuwait, right? And part of Kuwait, they were thinking, how do we leapfrog all of the problems by going now to people who've solved those issues and go straight to cloud, go straight to mobile first, go straight to digital. And because they're greenfield, not brownfield, they're able to do so. So I think we're going to see great technology. We're already seeing some amazing things happen. I think some fantastic healthcare models already exist in those parts of the world. And I think people should be watching out for those and not be thinking and thumbing their nose, oh, they're developing countries. That's not the way to look at it for me.
Yeah, if I could just add to that, I think one of the areas, again, that doesn't get enough attention is consumer innovation, or patient innovation, if we want to call it. And a lot of innovation actually starts with consumers, and then it goes into, so it starts really in that informal economy, and then is often adopted into the formal economy. So I think what you'll often see in a lot of low-income countries is that they're much more, as Hassan said, innovative. It's just that it's in their informal economy, and so it's not getting the attention. But, and there is research that shows some of those countries where you've got really lots of regulation, actually. So don't even underestimate developed countries. Often you'll find that there's these informal, just as an example, Facebook groups where people have illnesses. They're sharing information. They're often sharing ways in which to deal with their disease. That's innovation, but we don't often label it that way. And so, and there hasn't been enough real research into some of those solutions that are being taken forward by patients and customers.
I think that's what they say with long COVID. Long COVID came from patients diagnosing themselves, and now it's kind of a phenomenon that has been recognised. Okay, we haven't got much time for networking.
I just want to make a very quick point, just to pick up on that point earlier.
On the pandemic also. Thank you.
Go ahead. Very
so
interesting discussion.
One interesting fact is in Brazil, they actually started with telehealth in 2005, and they've actually really progressed it. And that was simply out of necessity. I got geeky one day and really started to read a lot about the case studies. And one of the major reasons is because you've got Sao Paulo and Rio, two very large areas, you've then got massive rural populations. And the other problem we have in Brazil is they don't have any train network. So to get on a bus takes a long time to go to a doctor. So just to pick up on the point about emerging markets and third world maybe countries, innovation is driven by necessity. So in Brazil, they just had to fix this problem because they had millions and millions of people in rural geographical areas. So often I think we're spoiled for choice in developed countries, whereas I think in other countries they're developing for necessity rather than kind of kudos or maybe for financial gains. But anyway, just wanted to make that quick point.
Yeah, I just wanted to make the last point. I thought about how can we prevent another pandemic. I have mixed feelings about it. So I think on the one hand, we've learned a lot from COVID in terms of technologies and data sharing, and also huge advances in pharma. But on the other hand, I do see if something again like this happens, the governments and the countries are really inward looking. And I think we need more cooperation and more collaboration in terms of, sharing the vaccines, sharing the findings, sharing funds even between the developed and the developing countries. And I don't think this is going to happen, given how the countries have responded and how they continue to respond in different parts of the world. And I see this as a challenge that, somehow we need to solve as the world become more globalized, but the countries at the same time are really inward-looking. So challenges for you guys to solve maybe in the next few days, few years.
You are the next generation.
Decades. Thank you.
That's right. Thank you very much for that summing up. So I think it does come back to what you and Furley said, and Jerry, George and others that I mentioned at the beginning. It's about communication, so it's great that we are here and talking to each other face to face and online. And coordination. I know I work as a hospice trustee as well, and care coordination and just that hub, as you said, Leonid, someone who actually brings all these proliferating platforms together that we can understand an Uber from an Amazon from a whatever is out there. So this is just the start, we hope, of conversations. Some of these people are, you're executives in residence, some of us. We won't let you go. We'll bring you back to speak to our students when they arrive fully in September. So we hope that you will keep in touch with us. We've done work with David Zagaran, his friend, his colleagues in cosmetic surgery. So as barely a one-year-old business school in an almost 200-year-old university, we're looking to innovate and to stay ahead of our competitors and the game when other people become the second business school for health. So please do enjoy our canopies and whatever else we have on offer for the next half an hour or so, and do talk to strangers and cross boundaries. I think that's our key message. And do tweet and keep in touch with us, and come and ask for tips from our serial entrepreneurs, managing consultants and academics. And good luck with your own innovative and entrepreneurial activities. So thank you. And there is a recording, and thanks to all those online people as well. You can watch on YouTube. Okay, so Adam? Adam's in charge of the largesse here. So do stand up.